you'll have it. And then as well, Dr. Giovinco brought some forms from DeKalb that we'll pass around as well, and he said those you're welcome to take one with a little bit of information about DeKalb on there. Does anybody have any questions about Surgery Club this year? No? Okay. Well, thank you for coming. And did everybody get the link with the article that will be discussed today? Okay, good. Okay, so without further ado, I would like to introduce Dr. Nicholas Giovinco, who is a third-year resident at DeKalb Medical in Decatur, Georgia. He'll be presenting some of his findings in a paper that was published in the Journal of Foot and Ankle Surgery this year, and the title is A Novel Combination of Printed 3D Anatomic Templates and Computer-Assisted Surgical Simulation for Virtual Preoperative Planning in Charcot Foot Reconstruction. Dr. Giovinco has several other publications, and each of them is with Dr. Armstrong. And I'm sure he'll talk a little bit about Dr. Armstrong today. But we're very privileged to have him here. He's an alumni of NYCPM, and so we're happy to have him come back and teach us, as he was taught by those before him as well. And so, without further ado, I'll turn the time over to Dr. Giovinco.
Todd, thank you for having us. I see that in the time that I left, the surgery club is now called the ACFAS Club, so I guess that's definitely a step up, and hopefully that can help out with helping you guys get out there and meet some people too. One thing that we always like to do, and I know the surgery club has people who are like first-year students, second year, third year, fourth year alike, and it's usually it's kind of a good way to get your feet wet as a first and second year student, because you start to learn maybe a little bit about what's out there, and it helps to correlate it with some of your preclinical classes. So maybe this could be something that's useful to you, or at least worth paying attention to, so you have a little bit of knowledge as you go forward in your careers. So the topic that I want to talk about, if you were going to simplify that long title to just what it was 3D printing for surgical simulation. I guess if you go with a really long sounding article title, it sounds more important, but that's really what it boils down to. So what we're going to talk about today really is just a very, very brief overview of Charcot Foot syndrome and just complex case preparation, which I know some of you guys that are in your surgery rotation, you guys do a lot of these templatings and stuff already with paper, so this is really just kind of an extension of that. And we use it for surgical simulation, and then we then applied it actually to help us with surgery itself, and then we made a publication out of it, and that's about all that is. If you look at Charcot Foot, I know in your clinical classes and such, they'll talk about the architecture and the shape of the foot, and when it breaks down you get these deformities. But Charcot Foot itself is really an overall syndrome. It's a metabolic bone disease, if you want to think of it. Some of the newer scientific publications that deal with some of these metabolic bone diseases tend to group Charcot as part of it. It has its own etiology, it has several of its own factors involved, but the overall end result that you can think about in bone metabolism is, bone resorption, bone deposition, and then there's that balance that exists. People who are losing bone, people who are osteopenic, they have a little bit more resorption than they have deposition, and over time that leads to a deficit. And if you look at the opposite, you have some people who tend to build up way too much bone or the wrong kind of bone, and that could be a scenario where they don't have a good balance of bone metabolism there, where there's too much deposition rather than resorption. Charcot Foot and patients with diabetes will often get osteopenia, which is a decrease in density of bone and bone structure. So the classic pathophysiology that you learn about in school, and I'm not going to go into the long details. It's still worth knowing, even though it's a little bit outdated. I'll start with neurotrauma, the German theory. They feel that this neuropathy happens. You don't necessarily feel pain, so you start to have these microtraumas that over the time can add up, and you start to get an overall breakdown of the bone architecture, and the joint integrity. Your next theory that was proposed is your neurovascular, your French theory, and by this they feel that the neuropathy and the decrease in sympathetic tone leads to an increase in vascular supply to the foot and the bones in the foot. You start to get a washing and a wasting away of the bone and bone structure, and then that leads it susceptible to break down. A lot of the modern theory now really tries to group these together and sort of unifies them to really being an imbalance in the RANKL OPG pathway, and that's something that's definitely worth looking into, but that's a whole entire lecture in itself. But overall, if we talk about the biochemical commonalities of Charcot Foot, no matter what it is, you're going to have inflammation. And I know in some of your clinical classes and in clinics itself, they tell you to look for the signs of a Charcot Foot, which are your what? Like, what's your presentation of it? Red hot swollen. You got it. And that's what we end up having. We have significant amount of inflammation and edema. There is an immune reaction, meaning you may see a spike in white blood cell count, not just in the overall blood that you pull from peripheral blood, but even locally there'll be a lot more white blood cells there. If you ever took a core of bone that was in the process of breaking down and sent that to the pathology lab, they would see all those white blood cells there, and they would think that there may be some bone infection. They would want a clinical correlation to rule that out because they see a lot of white blood cells in bone. You know, and if you, like you have from your histology classes and your pathology classes, you probably understand that the process of creating those slides also means that you destroy everything in the process. Nothing is living. You can't really culture bacteria from those slides and things like that. So they have no way of knowing without a correlation. There will be an angiopathy involved. There's always some sort of vascular pathology that follows this, and whether that's a reaction of long-term inflammation or if that's just kind of a response to the other factors involved that hasn't entirely been understood yet. There will also be bone resorption. Like we mentioned with the osteopenia, there will be a lot of bone resorption that's happened. The bone is a lot weaker and it's a lot more susceptible. People who do surgery on Charcot feet or even just diabetic feet in general will tell you it's not normal bone, and that's why a lot of times you see people taking a scenario where you may only fuse one joint and they'll fuse a lot of extra joints, or one screw in a young healthy kid might be enough to solidify that joint. You might put plates and screws and staples and all kinds of stuff. You really want to reinforce it because it's just more difficult bone to deal with surgically. And then calcification. And I know that I mentioned about bone resorption above that, and now I'm mentioning calcification underneath that. So I know that that might seem kind of antagonistic together, but that's generally what you see in what you'll see happen there. If you take an x-ray of some of these patients that have bad peripheral vascular disease and long-standing hypertension and metabolic syndromes, will have that vascular calcification that presents, but they will also have weak bone at the same time. So again, this is a bone resorption issue, and RANKL is one of the bigger control points. If you look at all the metabolic pathways that go on in all the cells of your bodies, certain cell types and certain systems tend to be more responsible with certain biochemical pathways than others. In bone, if you want to talk about bone processes and bone pathologies and things like that, the receptor activator of nuclear factor, kappa B ligans, definitely a big one. So if you ever want to look up some recent articles on RANKL, I think you'd be pretty impressed with the variety of stuff that it pertains to, not just Charcot. So the role of RANKL, and if I was just going to give you a brief overview so you have an idea of what to look for later on, or at least understand some of the technology or some of the terminology out there. It's a chemical signal, and it's kind of a common signal amongst a number of different cell types. So for example, in this illustration, they're showing an osteoblast, which is expressing RANKL on its surface. And if there tends to be, like you see on the left-hand side, not very much RANKL, but a lot of the OPG, the osteoprotegerin, then you will have less osteoclastic activity and you'll have a net bone deposition. If there's an increased amount of RANKL but not as much OPG, then you actually get increase in osteoclastic activity and you'll start to get bone resorption. And that would just be in a nutshell to sort of understand it, but there's a lot more that goes into it. But it is naturally occurring. It's not like it's a bad thing, and it's really not the presence of it that's the problem. It's the imbalance of those two that's really the problem. And like I said, it's implicated in a number of diseases. This is by no means a complete list, but you can see a lot of these that you see up here that do in some way, shape, or form affect bones. And you've probably heard about these in your pathology classes and even your basic medical classes. And this would be one of them right there on the bottom right corner, Charcot neuroarthropathy. It's there, and it is essentially a victim, so to speak, of that imbalance. So it's definitely worth looking into further, but that's probably about all the time we have. Now, how many of you guys have already, do you have any fourth-year students in the room? Okay. By the end of your third year, I think, unless they change the curriculum, I think you guys will take your traumatology classes, and just trauma in general is very exciting and it's cool. But one of the things you really need to understand is that class is a lot of memorizing not just the mechanisms, but the actual classifications that involved. So when we have students that come with us that interview at our program, and a lot of the other big surgical programs, they're going to ask you, some classifications. They might show you a broken ankle and they'll ask you to identify that based on some classification. I think for Charcot, my best advice for you would be to memorize at least one or two classifications. There's well over 7 that are published and actively used, depending on what specialty you're in. I think for podiatry, the 2 that I know I chose and I'd recommend maybe you go for is one is the Freiberg's, which is an anatomic classification. That's very easy to memorize, and it helps at least with some of your surgical planning and comprehending and understanding some of the literature that's out there, especially podiatry literature. Freiberg's is a very, very well-known name for Charcot foot reconstruction. And then the other one that I'd recommend is Eichenholtz, and that's more of a biochemical kind of clinical classification where it talks about the activity of from a normal foot all the way through the Charcot process to the very end result, which is a deformed but yet biochemically stable foot. So if we were to start here, we go with Eichenholtz stage 0, and this is kind of the modified version where they talk about there's joint edema, and there may or may not be positive scans, but the overall x-ray is going to look normal. And I will wager that that terminology would need to be modified slightly, because a negative radiograph would exclude vascular calcifications. But as we know with the RANKL and pathway and some of the effects of it, that it can cause vascular smooth muscle calcifications based on the fact that if you look at osteoblasts, fibroblasts, myoblasts, they all come from that same immunologic and stem cell origin. So if you have RANKL that can affect one of them, it's probably going to affect the other ones very similarly so. So you start to get calcifications. You can get fibroblastic calcifications like within a tendon. You can get myositis ossificans within muscle, and those can calcify as well, just like osteoblasts. If they're stimulated and there's RANKL present, they may actually lay down more bone by themselves. So I put all that in the same category. If you look at the next stage that you start to see, and this is by the time the patient may or may not be coming to the ER with you, and this is your osseous fragmentation and the beginning of some of your joint dislocation. It starts to loosen up. Here is often where, as you're a first-year resident, and this is a scenario that gets asked as an interview question often, is you have a patient that comes in, they have an ulcer that's very superficial, and they'll show you a picture of a superficial ulcer, which obviously isn't a good thing, but you can tell that that's probably not bad. But then they zoom out, or maybe they show you the whole foot and it's blown up, and it just looks awful. And the ER doc is going to think that there's a raging infection there. They look at the X-ray and the bones are starting to look kind of wacky, and they think that there must be an underlying significant osteomyelitis of multiple bones or entire portions of the foot, and they feel that this patient has a horrible infection, they need to be amputated. And your clinical knowledge and your understanding of Charcot Foot and the way that it presents, even in the presence of inflammatory conditions like an acute ankle sprain, or maybe they just walked around on it too much at the mall or at the the amusement park with their grandkids, or maybe even just the fact they have an ulceration that's inflammatory but it's not quite deep enough to infect bone, you can tell the difference. And this is when cast immobilization often comes in the best. And this is technically your acute Charcot phase. And this is not the phase you want to do surgery on by any means. Your next stage would be stage 2, and that's when you finally start to get a decrease in the local edema, and this can occur over several weeks or maybe even a month or so later on. You get coalescence of these individual fragments, they start to come back together, and then you'll get absorption of this finer debris. So the actual synovial biopsies and even some of the bone won't show quite as much inflammatory reaction. So if you sent a slide from this one down to pathology versus a slide of bone that you took a month prior, they'd look at the two and they'd think that, well, this first one was osteomyelitis and somehow, some way it's gone now in this next one, even though you may or may not have even put them on antibiotics. You just got the inflammation out of there, and you got the destructive process underway to quiet down. And then your last stage now is your last stage of Eichenholtz, and there's no more local edema. The foot, even though it's incredibly deformed, and as you can see in the picture here, it's definitely not a normal foot anymore, but there's no more edema. It's not this red-hot swollen foot that you mentioned anymore. And from the term stable comes into this classification, and I would encourage you to really be careful with how you use that word, because it may not be a raging Charcot condition. It's probably stable from a biochemical standpoint. It's not particularly always going to be a stable foot. You may actually have floppy portions of the foot that kind of move off from each other when you do your physical examination. Also, because it's deformed, now you have those bony prominences out of the plantar aspect. So you have to understand that just like you can wear out a hole in the bottom of your sock when you're walking around, or in your shoe, these patients will wear out a hole in the bottom of their foot. And in this case, we're showing the lateral column of that calcaneocupoid joint, which is most often going to be the one that gives you the ulceration if you're talking about midfoot bones. But in the case that we're going to present, we'll show you a gentleman who had a long-standing history of a medial column breakdown, with the cuneiforms and the navicular were kind of busting down and through, and they eventually got those healed up prior to taking them to surgery. So this is the way a Charcot foot will present in real life. You tend to have these, they're really lumpy, bumpy. It's not always going to be easy to distinguish which bones are and aren't messed up. And to be honest with you, a majority of these patients with a Charcot foot, I think that you would be wise to just not even want to do surgery on them. Try to go with conservative care, try to go with offloading, try to go with specialized casts and crow walkers and things like that. Taking these patients to surgery not only doesn't mean that you're married to them for a very long period of time, because they're going to have slower healing, but their adherence and the type of patient that you're dealing with and the personality, they're not always going to have the best results, and they're not always going to do their 50% of the process, which is to let themselves heal and to take their job seriously. So for example, this particular patient had seen my attending almost 2 years prior to surgery, and he was a very overweight individual, had a hemoglobin A1C of like 9, which could be a lot higher if you talk to some people in clinic. And he said, I understand that you have a deformity, and I understand that surgery may fix the deformity, but we got to fix you first. So he essentially told him and got him set up with a nutritionist, an endocrinologist, and a number of other people. One, to make sure his vascular studies would be well, but another was just to say if you can lose about 100 pounds and you can get your A1C down to about 6.5, in that range, then we can talk about surgery. So a year later, this gentleman came in, and they got him cleaned up. The ulcers were gone by then. He had been in a local wound care center, and when it was time to take him to surgery, then we proceeded further. But I think the biggest, one of the biggest things that a lot of people tend to think is incredibly glamorous is this Charcot Foot reconstruction, which it is. They're very cool surgeries, but you have to understand everything else that goes into it, and that's the very, very tail end of the equation is the actual surgery itself. So we look at these X-rays, and you can see here from this foot all the way to this X-ray, the bone structure, the architecture, everything is just incredibly busted out, and you start to get a very, very deformed foot, which is difficult to displace. You have to understand it may have been like this for a number of years, and trying to put that back, you know, after all that inflammation and all those scars and adhesions and the synovial capsules the way they are, it's not just going to pop right back into place always, and often it's going to be a struggle and it's going to be a big fight, and that's where some surgical techniques will come in and play an advantage. Anything cool? And then this is another view, a dorsal plantar view. And I know that when you guys look at like bunion deformities, you guys look at other types of deformities in the foot, it's always great to look at multiple views. And in this case, it's definitely no different. But what I think that you need to remember is that the more complex that these 3D deformities become, X-rays don't always tell people kind of outright what they're looking at. Some people who do these surgeries and deal with these kinds of deformities often can look at a couple of views and put together in their head what they're looking at, and then they can turn around and go to surgery with that. But for the lesser experienced, and that gap in between, the gray area from the time you come out of residency to the time that you're actually doing surgery, it's a big difference, and there's a learning curve there. So even if you look at a medial oblique view, you can definitely tell that midfoot, that Liz Frank joint is completely dust, but you're not quite sure what's on top of what and what's on the bottom and such. So this is the gentleman's gait examination, and you can see here he's able to walk to an extent, but he's really wearing down on the medial side of that right foot. And when he turns back around, you're going to see he's essentially he's putting a very limited amount of weight on that medial column. And he understands that he has a Charcot foot. He is neuropathic, but he tries to favor it when he walks. And he's obviously on camera, so he's going to protect it even more. But, I mean, even with the best of effort, he's still at a very, very high risk of re-ulceration and potential amputation and life-threatening infections and everything else that goes along with diabetes. It's pretty scary, and he knows that. So surgical planning, and this is probably something that some of you kids in clinic did today. You took a bunion deformity, you took a metaductus, and you draw these things out. We do these at residency. I see practicing physicians that'll do this from time to time. It's a very good technique, and it holds up pretty well for most things. But it doesn't hold up for everything. And even though you can measure the angles, you can look at an X-ray or a drawing from an X-ray in a number of different views, it's still sometimes hard to put together a real three-dimensional concept. If you wanted to do one silver bullet or one cut or one osteotomy like wedge that was taken out to bring everything together, it's better to have it done the first time around than have to get in there and feather and screw around. And some of you who have been in surgery have been in cases where you've seen they go in and they try something and it doesn't work, and they try something else and they try something else, and all that's just adding to the OR time. It could be the difference between a case lasting an hour and a half versus a case that lasts 3.5 or 4 hours, and then even longer. And that's not only an incredible burden to the healthcare system to have a patient under anesthesia that long, but these aren't always the healthiest patients to begin with. So the longer that they're under anesthesia, essentially the more at risk they are for adverse consequences. So what we did, and like you'll often do, is for severe fractures and rear foot deformities, and Charcot's no different, you'll get a CT scan, and that's completely within the standard of care. But that's often where it leaves off. You tend to scroll through it, and you look through and you see some of the fragments, or you try to maybe plan where your actual osteotomies are going to be. And all we did was try to spend the least amount of money and take it even further than what we could. And we worked with a number of different people, and like you mentioned, Dr. Armstrong, he's a very, very knowledgeable guy. It's actually impressive. You can meet him and you can mention anything about anything, and he at least knows something about it that he could talk to you about. I mean, you talk to him about 3D animation, you talk to him about, anything related to this research that we did. He was a big resource, and I was able to bounce a lot of ideas off of him and help to kind of develop our technique for what we wanted to do, and I was very appreciative of it. And so what you can do often at these diagnostic imaging centers, they have these algorithms that will compute and take those CT scans that are just digital images. If you really think about it, it's just a bunch of ones and zeros. You have your darkest points on the X-ray that are mostly light and air and water, and then you have your dense points, which are like cortical bone, and then you have everything in between. And all it really does is just it conveys that or presents that to you in a grayscale fashion, which looks like a film. But that's all it really is. It's digital pixels. So what a lot of these algorithms that these imaging centers can do, and these radiologists have at their disposal, is they can run a process that goes through it and pulls layer by layer all the different signatures of maybe a frequency that you want to tune into, like cortical bone, like whatever white count density would be for that. It would show it, and so you can make a surface reconstruction of the bone. But what we did was we were able to take that further. We could layer on multiple things on top of just the bone, so we're able to then superimpose another capture of data that was maybe less dense than cortical bone, but not as light as something like fat tissue or water. So we chose something that was kind of more fibrous, a frequency range that was in between for like tendons and ligaments, and that's what we had here. And if you look here, and this is a CT, most people think that this is an MRI reconstruction, but it's actually a CT. And what you can see here is the actual insertions and the courses of these different tendons that insert the back of the bone. And it's actually pretty interesting because sometimes you'll see where like the cuboid or a part of the architecture for the Charcot Foot drops out or it breaks apart. And yeah, that you can see where the bone is on a CT, but when you do it like this, you can actually see where the tendons are. You can see some of the vital structures. Those calcified vessels, which although they may not be providing a whole lot of blood, that might be all they have. So you want to preserve those. So to know where their course is and know that even in this derangement, you can still have an idea of where these things are going to be located so you don't whack one of the vessels when you're on your way through or end up severing one of the tendons that could be essential for further ambulation. We were able to plan our incision placement from these sorts of incisions alone. And based on what we saw here, we felt like we had a good enough pathway where one incision, medial and lateral, was going to work, and we were able to kind of measure out and palpate where we want those to be. So that's essentially what we did. But before that, we were able to take that physical model that you could view in the computer, and you can see on some of those CT discs when you get to like your radiology courses or when people in clinic show up and they have like their CTs that were done, they may do a reconstruction. You'll see those pictures in the computer, but we took it further and in special like illustrative CAM programs, the stuff that they use for special effects for like movies or the stuff that you would see when they make those renders of like those buildings that haven't been built yet. They take the blueprints and they actually create the insides of them. We were able to use the architecture of the foot in this case for our specimen. We were able to rotate it and move it around like a 3D model in the computer, almost like a sandbox. And we were able to try to cut out wedges of bone and reconstruct that foot in various different patterns to see what would and what wouldn't work. So if it didn't work, we hit the undo button a couple times and we tried something different until we eventually got not only the locations of where the apexes of those deformities were at, but what parts you need to cut to try to bring it all back together. So this was one of our simulations that ended up working the best. We were recording as we went, and you could see here that once we made our wedge resection, this came together a lot better. And you remember before where I told you that sometimes these things are scarred in and they're stuck in place. So even if you were able to kind of dislocate the bones, they may not want to go together so easily because of that soft tissue envelope, which is now working against you. So shortening is always a really good strategy, and that's definitely a pearl that you hear a lot of attendings when they talk to each other, like in the surgeon's lounge, and they're planning surgeries. They say, if worse comes to worse, just take a little bit extra bone because you can shorten, and people can live with a shortened foot, but that also affords you some mobility to be able to move the fragments around. So we had a conformation that looked pretty decent here. We were able to restore relatively a decent Meary's angle in the DP view, but we were able to get a very, very good view at the medial aspect. So we're very, very happy about that, and this was what we went with. And another point that's worth mentioning is that this didn't cost anything. Like I said, we took everything up to the standard of care and then tried to take that further without spending a whole lot of money. I think that you'll see in medical technology and surgical technology, everything just costs a ridiculous amount of money. And it's going to be the solutions that give the best quality care with the least amount of money needed to be spent that are going to be the ones that really win out, especially when we kind of got our backs against the wall as care providers, what options we have up our sleeves. So this was something that we were pretty excited about. And this is where I work together with that local, I guess you can call it a computer club, and they have at their disposal a number of different prototyping devices, and these are pretty interesting stuff, and I think that you hear about it more and more in the news. When I first proposed this idea as a first-year resident, nobody had even heard of a 3D printer prior to me even mentioning it, and then now you hear about them on the news, you hear about them on CNN and things like that. But this is that same regular model that you saw prior, and it was converted. That geometry was converted to printing instructions. You can see it here in the print bed as it's being simulated for an actual print. It goes layer by layer by layer, and it lays down a very, very thin layer of glue on powder, and then like one of those automatic kitty litter boxes, it sweeps across another fresh layer of powder, and then it goes back across like a laser jet printer, prints off more glue. And these layers can be, some of the newer printing machines can print to a microscopic level that you can't even see with the naked eye. And over time, in this case, it took about 9 hours, but it would reconstruct and make a printed foot. And this is one of the printers that's located at Freeside, Atlanta. And this is it printing off a number of different items here at the same time. You can fill the print bed with several different models, and it's actually making it. And when it's done, it'll sweep across and start over again. I don't know how long this video goes, but yeah, there it goes. Fresh layer, and off it goes. It starts with the next layer again. So it's pretty cool technology, and what's interesting to note is that this, as futuristic as it seems and as cool as it seems, it's actually been around since like the late 80s. You'd never believe that. But the problem is that these companies, very, very few companies control the patents for these, and a lot of them came out of MIT, they came out of the University of Southern California, etc., and they were research only, and it wasn't necessarily something that was opened up to the average person. But now it's been, you know, some 20 years later, the patents have expired. I mean, you can download blueprints and make your own 3D printer yourself. You could literally download the software that operates this thing, the real brains of the machine itself, and then on top of that, you could even fabricate the individual items from another 3D printer to assemble your own 3D printer. And it's gotten that sophisticated, and I'm not joking with you. So that's definitely worth looking up too. But the end result was that one of these machines, which previously would have cost, you know, much more than most of the houses that, you know, we grew up in, plus the car that's sitting in the driveway. Now we're able to get one of these things that was actually broken down and beat up and wasn't working anymore. It was about maybe $2,400 worth of money, and we kind of, you know, breathed some life into it with some investments here, and we replaced some of the parts with some cheaper parts. That actual printing head is not the original printing head that came with it. We took one off of an HP desktop like paper printer, and we rerouted that and changed its contents around in the way that it would process and made that into our actual uses. So there's lots of ways to save money here, and that's a whole other discussion. But the end result was that we actually had a 3D printed model of the patient's anatomy that we have. And I brought a couple here. These are some early prototypes that we had of different patients and such along the way. And as you can see, they don't really hold up too well with TSA. But the end result was that we're able to actually have a few. We're able to have a few just to bring here to talk about. They're colored in a number of different ways, but the end result was that we kind of just spray painted it white so it looked all nice and clean and stuff for the research project. But the actual binder that you use is an alcohol-based binder with like food coloring or something like that. Some of the newer, more sophisticated ones are actually printers that can print in multiple different colors, which is incredible to see some of the stuff that's out there that can be done on these machines. But anyway, the end result is that we were able to get a pretty decent anatomic overview of what we wanted, and the resolution was about maybe 1/20th of a millimeter. So if you added all that up, we got, which is something that was fairly accurate. And the good news is that it was to scale, so that was very, very useful for us. So we were able to plan our incision based on the simulation that we knew we had already done that worked well. We were able to take our measurements off of it that correlated well with the physical model. And what we did was we were able to kind of plan our access guides. And have you guys gotten your surgery courses yet where they talk about the access guide for like a bunion? So you know that that'll be where when you're making your osteotomy, you want it to end or begin right there at that point. So a closing base wedge osteotomy, you might use one of those, or like a chevron or a Kalish osteotomy, you might use one of those. Well, for these midfoot reconstructions, often they'll use access guides there, very, very similarly. In this case, we actually drove 2 access guides, dorsal plantar through the foot, and we knew that that kind of wedge, that wing, like chevron cutout that we were going to do, those 2 points were going to be from the incision line on the medial and lateral aspect of the foot, and then the access would be right there in the middle of the foot. And we were able to figure out what that was going to be. So we drove K-wires here to match that, and we just made our cuts all the way across the foot. And we were able to just kind of practice how much dissection we would need to be able to get the saw in, what kinds of saws we'd need, and even furthermore, it only costs about $40 worth of printing materials. So that we're also pretty happy about. But what's furthermore is that, you know, once we had that done and we had something that was usable, it you know, applied straight to the patient's foot. So not only were we able to palpate out our margins and our incision line, we could use the fluoroscopy, that little x-ray machine that's inside the operating room that you have, and under kind of a live scenario, you can sort of move it around and see different angles of the patient's anatomy in the bone during the surgery itself. So we were able to actually palpate out and find, you know, which correlated with the computer's laptop that we had sitting in the corner of the room, where we wanted those access guides to go that we had measured out prior, and we drove our access guides through it, just like we matched here. So that ended up kind of coming together very smoothly and saved a lot of time. So we made our incisions, we made our way down to bone with anatomic dissection principles, and then there's our actual entry points where we wanted our saw to begin based on the simulation that we did. And you can see here the access guide in the middle, we actually met it. If you're able to see, I don't know how good the resolution is, but you can actually see one of the access guides right in the middle of that osteotomy. So we caught that, and we made it connect with the medial and lateral side, and then it came together. So there's our actual cut, there's our access guide. We brought the saw blade right to the point of that access guide, and it reduced. And this is a intraoperative fluoroscopy image where you can see the screw placement that we use kind of as a temporary fixation means, because we're going to put a larger super construct on. But it matched our actual simulation that we did, and it saved us a lot of time because we knew where we were going to end up. And furthermore, since we had the print ahead of time, as you can see here, we had the rep drop off the external fixator construct equipment ahead of time, and we actually assembled that little erector set thing that you see in the back there before the case even started that night on that foot. That after we had corrected it and we got the reduction that we wanted, we basically sized up that external fixator and made sure all the measurements matched up to be able to fix that thing where we wanted to put our pins and everything through the night before. And then that frame we just took to the OR with us and autoclaved it right before the case started, and we brought it in and we applied it to the patient. So there was no assembly needed during the case. There was very limited amount of modification even needed. It's not like those little nuts and bolts you had to like figure out what angle was going to be the best. We already knew, and that saved us a lot of time. So that was a publication that we wrote up, and that was kind of where we went with it. But something that's kind of interesting is when I first started looking into this had been kind of explored like on a research level. It hadn't really been applied because you have to understand the computer technology guys that are into this thing, or even some of the radiologists that might understand it, aren't the ones that are actually doing the surgery. And nobody wants to get involved unless they're the ones being paid money. So just like I mentioned how these patents and things kind of got in the way of this actually being incorporated and even used. I mean, 3D printing's not even a household name yet, but it's been around for 20 years, and it's probably the coolest thing in the world we've ever heard. At least it was for me. So those types of barriers really stifle innovation, and they definitely stifle the implementation of this into medicine. So all we really did was just use it and put it to some sort of good use, and out we went. And this is a service that wants to charge you somewhere near $1,500 per print. I mean, the doctor doing the surgery doesn't even get paid $1,500 to begin with, so I don't know where they expect to get that money from. And some of these companies I talk to who are trying to offer this and are starting to kind of really prototype the business model to actually make something like this work in modern day, they're even saying that maybe, you know, the patient might be willing to pay for some of this. And to me, you know, good luck. I don't know if they're gonna be able to or want to. It's gonna have to be something that's very, very cheap. So you might go to Kinko's and be able to print off, you know, a number of pages, and you'll pay a reasonable fee for that. I think that's what's going to have to make actual 3D printing, not just desktop printing and paper printing. I think 3D printing is going to have to reach, you know, prices comparable to that before it's going to start getting used as commonly as it is. But that's not very far away, believe it or not. And I think the more you look up 3D printing, the more you'll see that it's being used every day in more and more ways, and cheaper materials and such. And then if you were interested, these are some CPT codes that we've started toying around with. Some of these insurance companies will actually pay for 3D renderings with interpretations. They will also pay for some supplies that are provided by the physician. So we're trying to see what will actually be done, because we want to put together a bigger study. And since, you know, budget's obviously a limited factor, you know, we're just going to keep looking into this. But this is kind of where it's at now, and I think that you'll start to see this being done more. And what's important to know, even if you don't take it to a 3D actual printed level, I think just being able to look at the images and being able to reconstruct these CT images on your own laptop for free is great. And there's a number of applications that'll do that. If you use a Mac, I recommend Osiris, and on PC there's a number of different ones too. A really, really good one is called Devise. We can talk about that stuff later, but those are some really good options. But yeah, that's what I got there. So thank you. And this little printer you see here in the background, that's one of the kind of assemble yourself, where all the blueprints are online, and you can order the parts from them, or you can buy the parts from a local hardware store, or order some of them, however you want to do it. It's an open source design that you just kind of assemble yourself. It's about maybe $1,100 worth of parts, and the end result is that you have a printer that sits at home, you know, and you connect it to your computer, and you make up a little 3D model or download something off the internet, hit the print button, and off it goes. So this thing makes little objects about this big, so it's pretty neat. But yeah, if you guys are interested more, I'd love to talk about it. And actually, this particular company that makes this one, because they actually sell these fully assembled, and that's how they make money to actually support their effort. But they're located out in Brooklyn, actually, believe it or not. So go check them out. But yeah, so if you guys have any questions or anything else? I know it's probably a lot of information. Yeah, Todd?
So as far as time, you said it saved a lot of time in the OR, which is when you want to save time, the patient open, assembling all that. How much time did it take you to go from the CT, like if you could just go from the CT, render the image, print it, work with it, and then assemble the external picture?
Okay. If you were going to group that whole process down, especially now that we've kind of got it down to a science now, we've done it enough times, I think that you can take the CT and go to a reconstructed image in a matter of like 45 seconds with the software that I have, and I can show you now, I have it installed on my computer, to take that and create a 3D model that's print ready. We have some algorithms set up, and one of the guys that I work with at Freeside, he actually does a lot of that programming in a language called Python, which is what some of these actual applications are written in. It's an actual, if you guys ever looked at programming language, it's very cryptic looking, but it's a bunch of instructions for the computer to follow. So he was actually able to make a scenario where you just have all the CT data, and you tell this application just to process that, and it immediately optimizes it and makes a 3D model out that's print ready and ready to go. And then the actual printing process, which is automated for a machine that's actually, you know, that's actually working correctly. It's not going to catch fire. You can set it and forget it, and come back about 9 hours later and it's ready to go. And the print bed can do about 2 of those at a time. And then, you know, practicing surgery in the cadaver lab. Probably one of my best recommendations for anybody, if you go to a residency that has a cadaver lab, spend as much time in that thing as possible. You know, it shouldn't be seen as a chore. Be up there all the time, practice work, practice suturing, practice cutting bones, practice dissecting, and all those kinds of things. So I think grand total for that, particular meetup where we actually, one or two of our attendings, plus like the other resident that was going to be in the case with me, we're there for probably about 20 minutes. And you see in the article, that was also when we did kind of that video chat where Dr. Armstrong had one on his end. We had actually had some printed and sent to him, and he kind of did some of his technique, because he does Charcot Foot surgery too, but his techniques are a little different than what our attending typically does. So it was nice to be able to contrast the two. And if yours doesn't work, a good fallback plan is what I put together here, and he used a completely different external fixator set. He uses Stryker's Delta frame. So it was pretty cool to have that. And that was, grand total, I think our chat with him online was about 18 minutes worth of time. So I mean, it all varies. But again, all of that, even with the $40 per print, is still ridiculously cheaper than actual OR time. 1 hour OR time, I think, alone is like $1,700 worth of anesthesia. Not to mention the staff that have to work there and clean the instruments, not to mention everything else that's factored in, plus the potential side effects of the patient actually not doing well with all that surgery. I mean, every hour they're under anesthesia, you're increasing and factoring up their chance of complication. Yeah.
How many cases have you used this technology on?
For physical prints, it's been used a couple, and even though we haven't published it or combined it yet for any sort of overall research, several of my attendings have been pretty interested in it, and they've actually done a couple of these on their own. The people at Freeside that I worked with, he's basically started his own side business where he'll do those. So you send him the anonymized CT data that gets stripped out, and some of the programs will do that automatically. You import the CT data, and then you hit an export button, and it strips the patient's name and information out of it and just sends the data back. So he'll work with that. That way it's all HIPAA compliant, and then he'll make prints and send it back to you. One of those there was one recently that an attending did, just not even a week and a half ago, I think. But grand total, I can't even tell you. I probably have to talk with one of the guys at Freeside to see how many of these he's done recently. But it's probably less than 20. We've only been doing this for about a year and a half. But now the actual 3D reconstructions that you can do in the computer, where you can sit there and virtualize and just visualize it, maybe pull it up in a program like Blender or one of those other animation cam software programs, and screw around a little bit. I think that's I couldn't even tell you, because there's another residency program in Atlanta, the Atlanta VA. We've worked with them and shown them kind of some of our techniques, and they use it very often, especially at the VA. You've got government resources there. You can take CTs to everybody that comes in for heel pain if you wanted. So they've been able to do this a lot more, and they do. So it's being used a lot, and it's pretty cool stuff.
What are the machines made of?
For the actual printing recipe that we did. So for example, that one printer that we showed, that big one, that's called a Z-Core printer. It's made by a company called Z-Core, and that's that particular model is the Z-Print 402 model or whatever it is. It has its own proprietary powder ceramic type formula that's very expensive. So we use some open source recipes where people all over the internet or all over the world have those old machines, and they found out ways to get it to work without the expensive powder. So this literally was concrete powder that you get from sheetrock. If you took the sheetrock and stripped the paper border on either side of it, and just took that gypsum, that white powdery stuff, and crumpled that up into dust and put that in the machine, that would work. So it's a gypsum powder that's very, very similar to what you get either from some of those high-end pottery stores for making your own pottery, like a craft store, or even sheetrock itself. And then the binder is an alcohol-based binder, and when the alcohol hits it, it kind of gets it to glue together and stick well enough. But one of the guys from Freeside is taking that even further, and he's incorporated some kind of glue. It's almost like a derivative of super glue into the alcohol-based binder that stays dissolved. So the end result is that it's pretty solid. I mean, even though this thing transported through the airport, it only cracked in big parts, but it's strong enough to dull a saw blade when you're working with it. So, I mean, it's very comparable to solid bone. Yeah.
When you autoclave it, does it?
Yeah. I mean, the actual bones, these actual printed models themselves, we don't autoclave them per se. I mean, we have no use to bring those in the operating room, and they wouldn't be considered clean even after you did autoclave them. But the external fixation construct that we measured, where all we had to do was clean that off and spray some alcohol and stuff to sanitize it, and we sent that down to the sterile processing department of the hospital called SPD. I think every hospital's got some equivalent of that. So we sent it down to SPD, and then they wrapped it up further and autoclaved it in their big machine off the plant. And but yeah, if you did autoclave, I don't know what results that would have. One kind of funny side note is if you look online, I know there's open3dp.washington.edu. It's an actual Washington University, where these guys have a bunch of 3D printers, and it's almost like a kind of a little hackerspace that they built of their own up there at a school. And what they've been doing is they're the ones who kind of, we copied a lot of their recipes and a lot of their techniques to do this research. And what they've done actually is they've done some pretty cool stuff. They've got some actual pottery ceramic powder that you can literally print off, and then you glaze it and put it in a kiln and create a real pot. So you can design it in the computer, things that you'd be like never be able to do with your own hands in real life, but you can create like these really intricate like pot designs and stuff like that. Another thing that they did actually, and this I think is kind of scary, but it's hilarious, they took actual bone meal powder, like from like farming agricultural uses when you like want to use fertilizer, and they used and made printed bones to animals that don't exist, like a unicorn, and scattered those out in the woods just to see if somebody would discover it. I mean, really just weird stuff, but there's so many applications for this. It's just unbelievable. But yeah.
Do you know if there's any other areas of like medicine that's doing this type of thing?
Yeah, maxillofacial or crenulary surgery is just out of control with this. They're using this a lot. For people who have some bad deformities or some congenital deformities like residual cleft palates, and people who have actually like had traumatic like car injuries where they've crushed their sinus cavity and they want to rebuild all that out. There was a recent article, I think it was, the lady was like 83 years old, and she had, I don't want to misquote this, so if I'm saying this wrong, then just ignore it, but I think she had cancer, jaw cancer, and they actually had to resect a big part of her jaw. And what they did was they just took a CT scan of her head, used the good side of her jaw, and just kind of mirrored that in the computer, and just made a digital copy, and they printed it out of titanium, and then implanted that into her. But that's at a research level. But there's a lot of research that's being done now with the 3D printing technology, and basically what would you be able to print off that would then still meet FDA guidelines for sanitation and the inability to be like implanting contaminated hardware into somebody to begin with. And I mean, these 3D printers now have gotten incredibly sophisticated. You can get stuff printed in titanium, stainless steel, gold, plastic, I mean, you name it, it'll do it. And not only are they able to make bigger and bigger things out of more elaborate materials, they've actually gotten better at printing small things now. There are some 3D printers on a research level that can literally make stuff that like you could design something incredibly intricate and have it sit on the top of a pen. You wouldn't even see it. That's how microscopic they are now. So we're going to start to see stuff where they're taking the actual input material rather than being concrete powder will begin to be scaffolds with like collagen fibers and stem cells of the patient that they harvested months prior to surgery. They'll be able to reconstruct parts of their body like a kidney or a bladder, things like that. It's incredible. So there's a, can't remember his name, but he's a researcher at Wake Forest University. He's been really involved in that kind of stuff, and he's done quite a bit. You can look him up. Just look in 3D printed kidney. He has a whole lecture that he has online where he's showing what he did with it. It's impressive. And it's actually being used in wound care where they're taking scaffolds of like skin and skin substitutes mixed with stem cells that they're able to just literally print off a sheet of like dermagraft, basically, but like a patient's own dermagraft, and put that on for like wound healing.
They do it with bladder, I think, esophagus also.
Yeah. Yeah, and they also did it with a gentleman's aorta, and this was like an actual, he was an engineer who was skilled with CAD-CAM, and he actually helped design his own aorta that the cardiothoracic surgeon implanted. So yeah, it's getting out there. Sorry, yeah.
So when you started this a year and a half ago,
Mm-hmm.
you get better output doing this ahead of time.
I mean,
Besides the OR time.
yeah.
Patients all post op.
I mean, saving. That's a very subjective question, and it's not a bad question. It's a very good question. I mean, for example, if you go to some externships, you go to some programs, you'll see attendings, and some of them get in there and they do the surgery and they're done, and then there's other ones who are going to sit there and they're going to be absolute perfectionists. They want everything to be perfect. And one of the reasons that I really wanted to go to the CAB was I saw a number of surgeons that were incredibly diligent and very, very kind of controlling and possessive of making sure surgery is like perfect as possible. And so for a lot of our attendings where we've done this, it's given us a better game plan going into it, but our end result is no different than what if we just get there faster. We have generally a better idea. And it's not something, like I said, we use for every case. And there's plenty of Charcot cases that we do that we don't necessarily need this. Like there have been some cases where we have like a Charcot out ankle where the talus itself is obliterated and you have the tibia articulating right with the calcaneus. And it doesn't matter what you're going to do there. Like a 3D printed model doesn't change your game plan because you have a big reconstruction you're going to do. You're going to open everything up. You're going to gut out that garbage talus and put in a femoral head graft and all kinds of stuff. I mean, you've got a lot of work ahead of you. So its uses, I'm not going to say is the most amazing thing in the world because there's still plenty of very, very good surgery that was done long before this technology existed. But it's still pretty cool. Coolness factor hasn't faded. Yeah. Any other questions or anything else? Or even questions about residency itself or advice about school or shopping, fashion, anything? Well, good. Well, if you guys are putting in requests for externships and stuff, definitely come down and visit DeKalb. I have a booth apparently tomorrow at the residency fair, and I brought some brochures that I think some of you guys have already had handed out. So if you have any questions, I'll make sure I give you guys my email address, and you guys can always be in touch with me. I think it's I was carbon copying on some of the emails that Todd put out. So if you ever have any questions about the residency specific, don't ever hesitate. And during some of your free time that you guys have, like if you have like a week or two off, come down and visit DeKalb. We have student housing. If you're just visiting for a week or if you're visiting for a few days, you can stay for free. Just take care of actually getting to the house, and we'll work something out. And you guys can shadow up the hospital and watch some cases. I felt when I was a student, your mileage may vary, but I felt the more that I watched and the more that I saw of the real world, the better it was able to study for stuff while I was in class. I had a better idea of what it was I was going after, or what the overall goal, for studying like pediatric deformities was. Now that I saw the surgery, you understand? So I'd say just be very, very proactive, and don't forget to have fun. Well, thank you guys very much, and very, very thank you to Todd for organizing this and just being incredibly professional about it. I'm very proud to see that. So good job. Oh, and just this is a side note. A lot of these patients end up non-weight bearing after these surgeries. So even if you put a frame on them and you have them in a wheelchair, there's no guarantees. And one of my friends sent me this video and was wondering if this is what some of our patients do. Even though we tell them non-weight bearing, they may still interpret it their own way. And so this kind of stuff can end up happening out there. So you guys want to be real, real careful out there. Never underestimate how bad your patients will behave when they hit the real world. So the hardest external fixation constructs that look incredibly elaborate aren't always going to do the trick. Anyway, yeah, thanks.